We are live now, doctor.
Thank you. Very good evening, everyone. And this is a live webinar from Glaucoma Society of India. And this is Dr. Satyan. I am the President, Glaucoma Society of India. We have an interesting session today on OCT, that is the clinical, how we can really pick up glaucoma as well as neuroophthalmic diseases from the OCT point of view. Today we have a very important person, Mr. Martin Long from Heidelberg Academy. Just introduce Mr. Martin. He is an MBA business graduate with 46 years of experience in ophthalmic diagnostic and surgical instruments. He has worked with the Keeler, Allergan, Humphreys, Zeiss, Axtrate, and Heidelberg Engineering, where he has been for the past 25 years in positions of head international sales and marketing, US General Manager, Area Director, Europe, and now Director of Professional Education. He has worldwide experience of ophthalmology, specializing in glaucoma and imaging. And Mr. Martin is part of the Heidelberg Academy, supporting educational events and teaching the clinical use of spectralis OCT for retina, glaucoma, and also for cornea. And more recently, the anterior, that is another equipment for anterior segment imaging and analysis. He has represented Heidelberg Engineering and the World Glaucoma Association as well. And of course, we know Martin very well for quite some time. And he's such a wonderful personality that he likes to help every one of us in picking up almost all kind of glaucoma, the spectrum, and as well as the neuro ophthalmic diseases from OCT. Over to you, Mr. Martin. We are eager to listen to you. Over to you.
Thanks, Dr. Satyan. Thanks very much indeed. Very kind introduction. This is the third part of the series, and we've already been through, what the technical points are on for good imaging. And last week, my colleague Grit showed you a live demonstration how we operate and what we're looking for. And now this session is really to get to, okay, what do we do with all the information now that we've got it and we've got good images? How do we interpret the information that we're getting from our OCT? So I'm looking at it mainly from the perspective of OCT, although there is some crossover, of course, clinically, because we want to look at fields and we want to look at fundus images as well. But I try to give you a little taste of various different cases and what you can see with your OCT if you know what to look for. Let's start with a classic glaucoma case, just to get you into the mood and show you that this is a regular process. Every single eye, I look exactly the same way. I can actually extract the fundus image from the OCT here, and this is very useful. Often I get sent cases to review from an OCT perspective, what's happening, and I haven't seen the patient. So this at least gives me an idea what the optic nerve looks like. And this is an infrared reflectance image. It's a structural diagnostic image. And healthy nerve fiber is very bright and highly reflective, as you can see up here. And sick nerve fiber is dull. And you can probably see that there's this little focal nerve fiber wedge defect and some notching inferiorly on the optic nerve there. So I can see that immediately in my infrared image. I get an impression, what is the neuroretinal rim looking like? And also probably can make some kind of assessment what the cup disc ratio looks like there as well. And I'm also looking at the vessel trunk, because the vessel trunk typically in a normal position is like a C curve. But if that's slightly out on a particular eye because of anatomy, that can change the position of the nerve fiber relative to your normative database. So just be aware that the vessel trunk comes into play when we start to look at interpretation of the scans. It's a three-step process, as we've tried to point out to you in the previous sessions. Step one, I look at the neuroretinal rim. Step two, I look at the peripapillary nerve fiber layer. And then step three, we look at the whole of the macular area and the thickness of the macula. I'm particularly interested to look at the ganglion cell layer, because that's where we think the origins of problems start, and we might see early signs of damage there. And particularly we will see patterns of damage very early in non-glaucomatous optic neuropathies even as early as 2 days to 2 weeks sometimes, if you catch the patient when they're having an event of optic neuritis, for example. Let me take you through step by step. We go step one, we look at the neuroretinal rim, and we do a radial scan for that here. And we do 24 radial scans around the optic nerve, and we identify Brooks membrane opening, which should be the true anatomic position of the disc margin. And then from that anatomic position, we measure from Brooks membrane opening to the surface of the retina, the inner limiting membrane, and we look at the minimum amount of rim tissue that the patient has. It's the worst case scenario rather than the best case scenario. And if you think about it, the idea of this is that we're taking the thinnest part of the tissue here, and you're looking probably very used to looking at your discs in this direction, but with our OCT, we're cutting down, slicing through the optic nerve. And you may be forgiven for thinking that maybe the thickness and the health of the neuroretinal rim is across here because you're looking in this direction down, but you may be overestimating the amount of rim tissue that the patient actually has when you try to look at your cup disc ratio assessment. And so the idea of this is that it's a more geometrically correct way of trying to assess the amount of neuroretinal rim tissue that we have. And if you think about cup disc ratio, we're looking at vertical cupping, if you like, but there's no anatomic position for the cup. It's actually this thick fibers of superior nerve fiber which is thinning, or this thick inferior bundle of fibers that's thinning, that creates the impression that we have a vertical cup disc ratio change, but it's actually the thinning of the rim. And the idea of this exam here is that we're measuring the actual rim which is thinning. So it's the cause of the cup disc ratio that we're looking at now, rather than trying to make a subjective assessment what is happening there. So that's a little bit of a change in thinking. From these 48 locations of Brooks membrane opening, we give you the area according to the anatomy. It's called BMO area, Brooks membrane opening area, and this eye is 1.93 millimeters squared within those identified marks of Brooks membrane opening, and that would be considered an average sized disc. And if I have an average sized disc and I look at what is normal, and we have our normative database down here, I would expect the patient to follow this green line right in the middle of that normative range. And in this case, the patient doesn't. There's a little bit of a dip here going nasal superior toward nasal, but there's a much larger dip, temporal inferior. The patient should be actually up here, and they're right down here outside normal limits. So I don't like the look of that. And typically, I think about my OCT relative to glaucoma, and I say 3 strikes and you're out. And this is strike number 1. I don't like the shape of this neuroretinal rim. And you may be sitting there thinking, well, I don't look on that profile there. I actually look over here on the sector analysis because that's what I've been taught to do. And I have to tell you, I'm not a massive fan of the sector analysis because these areas are very large and they can absorb small defects that you can actually see in the profile. So if you're not doing it today, please start looking more closely at the profile because it's more sensitive for very early cases of glaucoma. And if I would go then step 2 to the nerve fiber, which probably all of you are familiar at looking at, I can see the tissue very, very clearly, and I can see whether the machine has segmented that nerve fiber layer properly. We're not picking up any vitreous membrane here to give us an artificially thick measure, and the base of the nerve fiber looks to be nicely segmented. So then I can be very confident when I look at the profile and also the thickness measurements, and I can see that the profile in this superior area looks to be very nice, but in the inferior area, I've got a big chunk out of my nerve fiber. And that's consistent with what we've just seen of the neuroretinal rim. And that's consistent with the location that we've seen that focal nerve fiber defect in our fundus image. So unfortunately, for this patient, 2 strikes from my OCT perspective, thinking about glaucoma. And then we have 1 step to go, which is to look at the whole posterior pole and to segment all of the layers. So we do a scan right across the whole macula, as you can see there. And then I'm looking for patterns now. pattern recognition. I'm using my manual AI, which in 5 years' time, you won't need me at all because AI will do all of this and probably a lot better. But I'm looking at patterns. And if I go to my posterior pole map, this is a full retinal thickness map, okay, which is okay. As long as you haven't got comorbidity and you've got a retina condition to disrupt all of the layers, you're going to see patterns that start to look familiar to you from a glaucoma perspective, perhaps. I can see blue and purple are thin parts of the retina, and the hot colors, red and even look, snow-capped mountains up here, very thick parts of the retina. And I can see a purple river going to the lake here, that focal nerve fiber defect. And if I follow those axons to the ganglion cell, I can see that there's a little bit of notching here of ganglion cell. So I've already got a picture in my mind that something's going on. And it's not rocket science, it's just what you're used to. And if you're used to looking at these and you believe and you're confident with them, I just look here and here. I can see a big imbalance between a thick part of the superior bundle of fibers compared to the inferior, for example. And in glaucoma, as you know, we look for a symmetry, either within the eye or between the eyes, because typically that's how we see our patients developing. And this is the same principle. If you're familiar with the Humphrey field analyzer, is the glaucoma hemifield test. And this is the same that we're doing here. We're looking at the superior hemifield compared to the inferior hemifield, but from the point of view of thickness measurement. So these black boxes down here are at least 30 microns thinner than the corresponding box in the superior hemifield. So this is another indication that all is not well. And this is maybe another sign that we would look for if we're searching for glaucoma. Then I would go to the ganglion cell and look at the individual ganglion cell layer, which we've mentioned in the previous sessions. And a normal ganglion cell parafoveally would be like a red kind of donut shape, thick ganglion cell parafoveally. But in this case, we've got an imbalance, and glaucoma is a horizontal orientated problem. So I look across the horizontal midline and I'm looking at just these two boxes to start with. What are the values of average thickness in these two boxes temporal to the fovea here? And I've got 46 compared to 25. And if the average thickness around here, typically in a normal eye, would be early 50s, let's say, we've even got snow-capped mountains here, 58, 59, but I've got an obvious imbalance here and notching and loss of ganglion cell. So, okay, it looks like a snail shell in the earlier stage of the disease process. And then I would follow my axons, and have I got a little notching of my nerve fiber? Have I got a defect down here? And have I got a depression inferiorly in the optic nerve? So this kind of completes the picture, except for one last step. One last step, we go to what we call our deviation map, which is a comparison of all these values of thickness compared to normal. And I've been used to looking across here, just parafoveally, to see whether there's an imbalance or notching here. But actually, when you look at the deviation map, you realize the problem starts much further out peripherally, temporally, follows the horizontal midline in towards the fovea, and that's let's say the thinning of the ganglion cell layer there. And if I click on the nerve fiber, I can see that inferior arcuate defect very nicely. Now we have a complete picture. And I can tell you the deviation map is becoming increasingly more important, because it sometimes shows you patterns that you didn't realize that were there that might indicate you might not have a glaucoma eye. You might have something else going on, some other optic neuropathy present when you thought you might have glaucoma, because that's what you were thinking. So this is the basic process that we follow every single eye. Okay. Let me show you a different one. This is a chap, 42 years old, and I've been sitting with a glaucoma specialist, a lady, and she said to me, can you please show me how to interpret the OCT? And this is at South African Ophthalmology Congress about 7 or 8 years ago now. And on Saturday morning, she came and said, would you mind scanning my colleague? I said, yeah, no problem. He was diagnosed with glaucoma in 2001. So if you have a quick look on the discs here, you can see that they're very cupped out, both eyes, but uniform, fairly uniform rims, but very, very cupped out. So you can perhaps imagine why he's been put on medication since 2001 for glaucoma. But let's see what we see with our OCT. So again, three-step process from the rim. And you can look on the rim here, we can see all of the locations of Brooks membrane opening. Makes sense, they're nicely followed around. It's quite cupped out, thin rims, a completely diffuse neuroretinal rim, and he's 42 years old. So something's happened, and I would have expected to see an extremely thin nerve fiber as a result of that, looking at the neuroretinal rim. But if you look at the nerve fiber, it actually is not too bad. We can see that there's a couple of nice thick areas, temporal superior, temporal inferior, but it looks a little bit thin on the edges here, on these temporal areas here, okay? And that's what's flagging up here. So when you see temporal loss, the question is, just be aware that could be related to neurodegeneration or thinning because of glaucoma, but equally it might relate to a non-glaucomatous problem, because we see nasal temporal changes in cases like MS, for example, rather than inferior superior changes that we see in our glaucoma patients. So a little yellow flags going off in my head when I see these temporal areas to start with. Let's progress further and let's have a look and see what patterns we can see on the retina to give us any more indication what's going on here. So we go to the posterior pole, and we have a purple eye. And when you see a purple eye like that, it means it's a very thin looking retina. And why would that be? It's quite atrophic. What would be the cause of that? Is that neurodegeneration or thinning because of the glaucoma, or is it thinning because of something else? And we can see a strange pattern. Normally we would expect to see a nice circle or an island here of thick ganglion cell, but it looks like the sea's come in completely and flooded the land and created an island here. And we've got this channel going right round here, right across the location of the papillomacular bundle, which is the last area to go in glaucoma. And we've got this funny green fringe, very strange looking pattern. We don't have an obvious asymmetry. If we look at the asymmetry here, it's all fairly uniform. And then if we continue our exploration and go to the ganglion cell layer, then it becomes very obvious, and probably by now very obvious to many of you as well. We've got a vertical loss of ganglion cell, first of all, and that is not what we expect in our glaucoma patients. We expect a horizontal loss, either more commonly inferior loss rather than superior, but we can have either or. But this is a vertical loss. And also the loss is in a wrong location for glaucoma. We're expecting it to come from the temporal side in towards the fovea, not going nasal to the fovea and temporal to the disc. So we've got two areas of thinning here which are not consistent with what we would expect to see in our glaucoma patient. And if you then look to the fellow eye, it becomes even more interesting, because I'm sure you probably can guess what happens in the fellow eye, but let's bring him up. There we are. And we have a similar pattern. We have a purple eye, but here we have a temporal crescent here. We have no imbalance that we see in a glaucoma eye. And of course, what you can see there is we've got a pair of vertical hemimacular ganglion cell loss, and it's left-sided. So just by looking on those patterns, you would recognize immediately that that has got to be a post-chiasmic problem, either left optic tract or left optic radiations problem, not something that you would associate with glaucoma. So I said to him, I'm really sorry, sir, these are not patterns of glaucoma that I recognize. And then he turned around and said, oh, I forget to mention to you that I lost my vision for a day in 2003. I've been examined by numerous ophthalmologists. No one really been able to tell me anything. I said, I'm very surprised about that. Have you had your fields done? And he said, yeah, I've had loads of 24-2 Humphrey fields and they're clear. And I said, oh, very surprising. I would have expected to see at least some kind of vertical field loss. Have you done a 10 degree, a 10-2 field? And he said, no, I've never done a 10-2 field. So maybe in this type of case where you've got a very central area of loss, a 10-2 field might be useful to do. I said, in that case, would you mind if we did one more little exam for you? Because we have another exam that we can do. I just want to check how your papillomacular bundle looks like. This is for neurology. And he said, yeah, no problem, we can do that. So we did a second exam, which is something we called EnSight. We haven't mentioned this, but just to show you, this is really for neurological cases and has been used a lot with MS patients, because we not only look at thinning, but we look at thickening. So we've got light blue here for borderline thickening, and we've got purple for outside normal limits thickening. So you've got thinning and thickening possibilities to compare to. And in these cases, we isolate the papillomacular bundle and we look for nasal temporal changes, because that's what we expect to see in those type of patients. So sure enough, he's got temporal loss of nerve fiber, and he's got outside normal limits papillomacular bundle, and he's got nasal temporal thinning. And in fact, if you look at both eyes together, there we go, you'll see we've got symmetrical bilateral temporal loss of nerve fiber. And in fact, in the left eye, the papillomacular bundle is still in a normal level, but it's bilateral. And this is not something that we would expect with our glaucoma patients either. So I said, well, I'm really sorry. Maybe you should have some further investigation. So he did go and have an MRI scan without contrast, and it wasn't conclusive. And he went back and he had an MRI scan with contrast, and this seemed to show a spinal problem. And then subsequently, his glaucoma specialist diagnosed him with neuromyelitis optica spectrum disorder, based on all the information. So I've had a couple of neuro-ophthalmologists tell me that I'm not even sure that that's correct either. But the moral of the story is, with your OCT, you could identify that here's a patient who's been on medication for glaucoma since 2001, and this is about 7 years ago now. Didn't know about anything else, but the patterns that you see on your OCT suggest that this is not really a glaucoma problem. It might be something else. And that's a very interesting case, and I don't know whether you have any questions about that one, but just to show you what you can see with your OCT if you know what you're looking for. Manesh asked me, can I see a high myopic glaucoma patient? And I said, yeah, I think I've got one, and maybe I can show you. Let's see. We'll bring that here. This is Japanese eye, highly myopic, with a large area of peripapillary atrophy, you can see there. And so in these cases, there's a lot of disruption to the optic nerve structure and the nerve fiber layer around it. So sometimes you can't get reliable information from your OCT. So if I follow my protocol and start with Brooks membrane around the disc, we can see that we've identified Brooks membrane opening as halfway in between the whole area of peripapillary atrophy. But if you have a look over here at the locations, you can see as you go around, these locations change. And so you can't rely on that information. As much as I love my spectralis, I can't rely, and I wouldn't trust that to be really such a reliable measure. Although it looks like a temporal inferior loss here of neuroretinal rim, if we believe it. I'm not sure about that. I would. If I go to the nerve fiber, we have 3 nerve fiber circle scans at different diameters, and the most commonly used one is this one at 3.5 millimeter. But I wouldn't trust this one because the nerve fiber is all disrupted here, and you can see the profile is completely disrupted. So I wouldn't be happy with that. Even if I try to move outside, you see that the nerve fibers still continue to be disrupted. And in fact, you've got cystic spaces here where maybe the membrane is pulled up, and or maybe because of the PPA here, you've got disruption to your nerve fiber. So you can't trust that measurement today, and you can't trust whether or not the patient would be progressing at all. So the best thing you probably can do is default to the posterior pole and have a look at the patterns that you might see of ganglion cell loss, because that would be more stable location anatomically than that closer to the disc and around the disc. And if we look at the posterior pole here, we can see now something that looks a little bit more familiar to us from a glaucoma perspective. These are very thin areas here, and we can see an obvious asymmetry between the upper lower hemifield there. And if you go to the ganglion cell layer, now I'm feeling very much more confident and comfortable because I can see this classic inferior notching adhering to the horizontal midline that I might expect to see in a glaucoma patient if I'm worried about this chap from a glaucoma perspective. And if I look at my deviation map, I can see this is the pattern that I would be more familiar with, starting right out peripherally, going in towards the fovea, and so on. So that would be the advice that I'm always giving if I'm asked, what do we do with a glaucoma patient with highly myopic, large areas of PPA? Manish, I don't know if you have any questions on that, because you were the one that were asking, what do we do with these ones? You're on mute, Manish. You're on mute.
I think we'll just go ahead and then we can have the questions later.
Okay. Let's have a look at a progression. And we showed a progression in the live demo, but let's look at a progression from the point of view of the retina rather than the classic nerve fiber. And this is a patient that I thought was a fast progressing glaucoma patient. 2 years, we got 4 exams. And if we look to the posterior pole, our retinal thickness map, it doesn't look too bad. What I would point out is that we see a little channel here appearing. And when you start to see this channel, just question, why is the retina becoming thin in this location where we're not expecting it from a glaucoma perspective? And if we look at the sequence of the 4 scans, we go to the follow-up now. It didn't seem to change much. If we go to the 3rd one, it didn't change much if we look at these boxes. And if we go to the 4th one now, we see quite a bit of change here and here. And we see this channel appearing in here, and we can see the difference here. There seems to be quite a bit of thinning generally going on. So what's happening here? Let's look a little bit closer. Let's go backwards and let's look at the ganglion cell. So we have 50-50 across the horizontal midline, absolutely normal, nice looking, healthy.
Martin, can I just disturb you for a moment? Can you just tell our audience that how to look for the progression from both the optic disc as well as from the GCL patterns?
Okay.
How to look for it? Because all of us have the habit of seeing the printouts, but we really, most of them, they don't access the systems directly. So how to look for the progression in the OCT for both glaucoma as well as the other things? That will really make a lot of sense.
I was going to show that in the next case. Shall I go to the next case?
No, you can go ahead. Whatever way you want to do that, please go ahead. But
I was going to
for
show
all
you
our audience to understand how to look for progression.
I just was probably following because Grit did the progression case that I normally open with last week. I thought most people might have seen that, but maybe not. So we'll do another one, which I was going to do anyway, to show you how stable the measurements can be over time that you can expect, perhaps. Just to finish this one, we have at baseline looks to be quite a normal looking ganglion cell configuration. If we go to the second exam, there's not much change. There's a little bit more washed out, perhaps a little slightly thinner perhaps, but now here superiorly, which fits the idea maybe of a glaucoma. And then by the fourth exam, we can see now, look, we have 27 compared to 39. So there's very much a superior looking notch there, which is familiar to us from a glaucoma perspective, perhaps. But here's where your deviation map may give you additional information. Let me go back to the baseline and pick up the deviation map here. At baseline looks to be relatively clear. Nothing happening. Follow-up exam, we start to see a couple of little areas appearing. And then third exam, some more. And it looks to be superior. And then fourth exam, after 2 years, we see a pattern that looks like a red circle sign. And that's not a pattern that we normally expect to see with our glaucoma patient. We're expecting to follow the horizontal midline and start out here temporally and come in towards the fovea. And this is not quite what we're expecting to see. And then we realize this patient is actually quite young. He's only 24, 25 years old. So is this glaucoma or is this something else? Because this would be normally more associated possibly with MS, possibly with a toxic problem, somebody with a drug problem or an alcohol problem, perhaps. And unfortunately, I was collecting lots of cases and I didn't realize what I was looking at that time, thinking that this was just a fast progressing glaucoma. And I'm not sure that it actually is. Now I look at those patterns. But just to give you the idea, what you can see over a period of time. And you could look on the whole page, let's say, like that, and see the progression over that period of time and see what's happening. And that's a very fast progressing, especially even from a glaucoma perspective. Just to come back to you, Dr. Satyan, we have a patient here, Bruce, 5 years. We've got 8 exams for Bruce starting in 2015. And if I go to the very first exam, just looking at the nerve fiber, you can see that his nerve fiber is quite thin, and it's especially thin here in that temporal inferior area. So if I click on here, you can see 43 there, which is the thickness at that point there. And we know that there's a floor effect when we look on nerve fiber. And once you get down to about 40, you're probably not going to lose any more tissue. So let's see what happened with Bruce in that location there over a period of 5 years. And we've got 8 exams. So just look here, we've got 43 microns. 44. 43. Come on, software.
It has become a little slow, yeah.
Yeah, oh, it's gone. Ooh. Maybe we timed out. I don't know.
No. Yeah, still there.
Oh. On my end,
Yeah.
I've lost my page. Sorry.
No problem, no problem.
A glitch. Doesn't like Zoom, obviously.
Yeah.
Try again.
Yeah.
Here we go. Sorry.
No worries, no worries.
Don't know what happens there. Come on. All right. Can you see my page again now?
Yes.
Or do I share it? Or do I need to share again?
No, we can see.
Okay. Here we go. All right.
Yeah.
Get back to Bruce. Here's Bruce again. I'll try again. Sorry about that. I don't know what happened there. Here we go.
Yeah.
All right. Well, we were going to wait all the way to 8. remember we were at 43, and after 5 years, he's still at 42. So nothing really changed in that location there. So you could say, well, that's great because we immediately put Bruce onto treatment when he first came because we could see that that was an obvious glaucoma defect. You could say that, well, that's great because nothing changed and he's stabilized. You could also say, well, we're not expecting to see any change there. Or you could say, that seems to be quite a reliable progression sequence. I could be confident in my management of my patients. But a better test would be to come over here and have a look on this temporal superior hump where there's still tissue to lose. We won't lose any more here. So at the end of the sequence, after 8, we have 1, 2, 1. And if we go backwards in time, let's hope it works this time. We got 120. 123. 122. 122. 122. And 118.
Martin, can you just explain that within the bracket, what was given is like -1, 0, -5?
In the bracket is 5 from the previous exam. So we've gone down 5.
Is it from the previous examination or from the baseline?
From the baseline, yeah, from the baseline.
Yeah.
So we can track what's happened just by looking on the profile, if you want to look at it that way, just to show you. It's really just an example to show you that you can get very good, consistent measurements. And in this case, the patient is not changed, which is great. But it's an area of tissue that's still there, considering that this is already gone. Just as an example to show you what you can see. And if you look on the progression, you can see the sequence there. This is that's the rim. Here's the nerve fiber. He was already outside normal limits when he first came to the clinic. So, but the slope of change is very small. If you imagine the average nerve fiber loss is about half a micron a year. So you can plot what change happened here. Look, we've got 70 microns, still 70, 70, 71, 70, 70, and a little dip at the end, 68. So just to show you how consistent the measurements can be, and the way that you might monitor your progression. So this is a nice example, but maybe less real life that you see in your clinic. So
Martin, just keep that slide on. I mean, that page. And
yeah,
would like to mention that how to look for the progression, whether it is in the MRW and in the RNFL 3.5. Looking at the right bottom, that
yeah.
we have the temple superior, temple inferior.
Yes, let's go there. Let's go, because these are the hot spots for the glaucoma. So this is the global.
So usually we should look at the inferior temporal or superior temporal in glaucoma so that we have very
This
precise
is not such a good
understanding.
example because he's already flat down here. Okay.
Right. So will you be really looking into these areas for the progression, or will you look at the areas of other areas where it is not flat?
Yeah.
The floor
I think this is not a good example for that. Let me go to the one that Grit showed last week, because that was the one I normally open with to show you. Let's go to this one, all right, because this is showing you much clearer how we look on that progression.
Yeah, I think that is very important for all our audience to look at how to look for the progression in an OCT.
I didn't show this because Grit showed it, but I thought you wouldn't want to see it again, but we can do that. So again, from the beginning, we go here, we've got the baseline scan and it looks okay. I don't know why the patient came, maybe because the cup disc ratio was looking very suspicious, or maybe there's a family history, I don't know. Here's the follow-up. It didn't change really too much. Third one didn't really change too much. Now here's the issue. Here's the fourth one, and now we see a little little dip there. Look, 26 microns from the baseline. And the important point here is you see this in the profile, and nothing is giving you any indication up here to let you know that there's a problem. So this is why I urge you to look on the profile if you can now, because this is more sensitive. This has been averaged out in the sector there. It's not showing up. If we then go to the 5th exam out of 7, now this got wider and a little bit more deeper. It's still not showing up over here. So that's not helping you. And then the 6th exam, look, if I go to the bottom there, 81 microns down from the baseline, much wider. Now, finally, look, after 6 exams, we're flagging up over here with a borderline problem. Okay. But
Yeah,
we knew
thank you
this
for showing that.
3 exams ago. Yeah.
Thank you for showing that. This is what I really wanted people to really
Yeah.
see.
I think it's really, for me, it's really important that that you all look on the profile if you're looking for early sign of glaucoma change, because that's where you're going to see it. Okay. And then you can look on the progression sequence here. And this is more important to look on because the average is still in normal. Okay. And again, you can see here 91, 94, 92, 89. Let me just move my pictures out of the way. There we go. 87, 88, 83, 84. So you can see that it's a very slow sequence, 1.1 micron. So it's like maybe twice the normal aging. It's just sloping down. And he's gone from 52 years old to 62 years old. So this is over a 10-year period. But more importantly would be to look at that temporal inferior area, because there you see a much bigger drop, because that's the location. So that's why we really need to look on focal areas and not just the average nerve fiber or average ganglion cell. We need to look at focal changes, from my opinion, because that's more important. And I think in this case, having seen this drop here, I think at this point there was the discussion where with the patient, maybe we should start to do something. Maybe we should put you on some medication to try to stabilize it. Yeah. But unfortunately, he continued to go down in that temporal inferior area. So he's still only in borderline from that point of view, but he's certainly moving.
Can I just?
It's thicker in the temporal inferior area. But
Can I interrupt you,
he's losing
Martin?
4 times the amount. He's losing 4 times the amount of normal loss in that sector. That normal loss would be about 1.25 in that temporal inferior sector, and he's losing 5.
Yeah. Just to understand a little better, when you have the RNFL 3.5, and when will you say that there is a significant change, that we have to say that, okay, there is a significant progression?
Yeah, I think commonly it's when you see at least 2, and depends how conservative you are, 3 subsequent deterioration or loss of tissue. At that point, you might decide clinically maybe we should think about it. But that's your decision as clinician.
How many microns you feel is significant for us to say that there is a possible progression?
I think if you think of consider the variability in general of OCTs is reckoned to be 5 microns. I would say if you're starting to see 2 standard deviations, let's say something between 7, 8, 9 microns, going up towards 10, because the average thickness of nerve fiber that you see in the clinic is between 80 and 100 in normals when they come to the clinic, if they're suspects of glaucoma. So if you're starting to see 6, 7, 8 microns of change from the baseline, that would be a little first alarm bell, I would say. But look at the focal changes, not the average overall. You're missing the point, really, if you're looking at the average. Yeah.
And once we touch the red zone, do you really again start seeing those areas, or would you really not consider after once it comes to the floor effect, would you really still keep seeing
No,
that area?
this is a common question, actually, because people say, my patients don't like doing visual fields. Can I just do OCT? And I say, no, you can't just do OCT. You must do the fields as well, because you need to know what the function of the patient is. And unfortunately, for those patients that continue to progress and continue to lose tissue, after you get down to the level of 40, you're not going to see anything more on your nerve fiber layer scan. You might see some continuing loss on your ganglion cell. That's what they say. So you might switch to ganglion cell. But at the end of the day, you've only got your visual fields left. So you need to continue to do your visual fields, because that's really all you've got left in order to make any judgment whether or not the patient's still progressing. Yeah.
Yeah. Yeah. Thanks for, showing up what is very important in how to look
Yeah.
at the progression in the optic disc and the RNFL area.
Yeah.
Would you like to show some examples in MRW in case if you have one?
Um,
Same patient, you have something in the MRW?
I think, let me just see, because I'm not sure if we had this patient towards the end started getting the MRW. Okay, so maybe we can have a look there.
Yeah, because so once you have this kind of optic disc scan, you can see the
Well,
progression
when
both
this,
MRW as well as in the
yeah,
RNFL.
yeah, this was before MRW, so we only had 3 exams with MRW, going from
Look at the bottom
255
screen. Yeah.
248. So we haven't got enough information. He needs 4 exams to be able to show. So this is when MRW kicked in towards the end of this patient history, and I don't have any more, unfortunately.
So we need to have a minimum of 4.
Yeah, and this green line is the normal aging slope. Okay,
Right.
so he's already below the norm, even there to start with, from point of view of the rim. He's still not got down to borderline, but he's below the normal aging. Let's put it that way.
Yeah.
He is if you go temporal inferior. If you go temporal inferior, he is where the problem is, but he's right down in borderline, but he started almost at borderline anyway. Yeah.
So this is exactly what I wanted to, show how
Yeah.
to look for real
But you
progression.
see, we had the previous circle scans back to when he was 52. This only kicked in 7 years later when he's 59 now.
Right.
Now he's 62. Yeah.
Now this is just to
So we
show
didn't have enough
how the
information.
progression needs to be seen.
Sure. Yeah.
I had one question, Martin.
Yeah.
So regarding the image qualities, so the data doesn't seem
Yeah.
to be very reliable once the image quality drops. So how do you factor in, or where do you look for the image quality? What is acceptable image quality? What is not?
Okay. Okay. It's down. Can you see right down here?
Yeah.
We've got a quality of 25. Okay.
In the bottom right.
There, that quality measure there, 25. Can you see that?
Yeah.
Where my cursor is down in the bottom
Yeah, I can see that. Yeah.
right-hand corner there. We consider a high quality image to be 30 or over. So it's a little bit lower than the best quality, but maybe that's the best you can get depending on what the patient's eye is like. He may have cataract, he may have some other disruptions which reduce the quality. It may be the best you can get, but at least you get some indication. If it was a baseline exam and I had a quality of 20, then I would say, please, can you rescan the patient, because we may be able to get a better quality than that. And that comes back to your operator to make sure that they're focused correctly, and then they're in the right position. So there's a little bit of technique from the operator perspective. But you do have an indication here. So I'm looking mostly for 30 and above in that quality area there. I don't know whether we go back maybe to previous one. Maybe we can, let me see. We go back.
Martin, you can show, after this, you can show a little bit more examples and then we'll have questions later.
All right. Okay. If you like. Let's see what we've got here. Different exam, a different quality. Let's have a look. No, this one's a lower one, 22. So that didn't help. What did we start with? Let's see. 23. So this patient already was quite low quality anyway, but that's maybe that's the best that they could get from him. Go back to my classic one and see what quality we got there, because we didn't look. $27 for that one. Okay. So not highest quality, but okay. Have a look there. 32. So we're getting a little bit better on the left eye there.
Yeah.
Okay. Basically, if I would see a quality of 20, I would try to rescan the patient and see if I could get a better quality scan.
Right.
Okay.
We'll have some more examples on non-glaucomatous if you have.
Yes, if you, I have lots if you want.
No, we'll have quickly because the time is.
Let's have a look on this one. Let's have a look on this one. This patient coming to glaucoma clinic, and let's look at the left eye. And I don't know what you think about the look of that disc, whether it looks a little bit suspicious, but this is the baseline disc image, if you like. We can see an area of peripapillary atrophy, a little bit thin temporally. And we go through the same procedure. Look at the rim. And the important thing to notice here is that it's a very subtle difference. And if you're used to looking on these, you might notice it. But look, we have a temporal, looks like a temporal depression of our neuroretinal rim here. Okay. Superiorly and inferiorly, and that's what's flagging up there. So that's the first thing to observe. It's not a general depression, it's on the edges here, temporally. Then if you go to the nerve fiber, you can see the tissue very clearly. You can see that it's a little bit up and down. But in general, look, it's very, very thin here in that temporal superior area, and also the temporal inferior area as well. So a little flag is going off in my head. What's that? Because we're thinking glaucoma. In our minds, we're thinking the patient's got glaucoma. Let's look at the posterior pole. Now look, you've got a purple eye. When you see a purple eye, that's a sign telling you that you've got a thin atrophic retina. Why have I got a thin retina? Is it because of neurodegeneration, because of glaucoma, or is it because of something else? What else would cause a thin retina? Is the patient highly myopic and may naturally have a thin retina, but they have to be like -8, -9, something like that to have an effect of a really purple thin retina like that on your OCT? Or have they had some vascular occlusion that might have caused a thin retina? Or have they had an event of optic neuritis that may have caused a thin retina? So you go through a process of elimination in your mind. There's not really any obvious asymmetry that we would associate with glaucoma there that we can see in that asymmetry map. And if I go to my ganglion cell layer, it's very thin. The ganglion cells almost are shot, especially over here. And you say, oh, look, there's some notching there. That's a glaucoma notching. I say, I'm sorry, that is not the right location for the notching that we expect in our glaucoma. We would expect it to be over here, coming temporally towards the fovea, not nasal and temporal to the disc. So that's a complete wrong area if we're thinking that that is a loss of ganglion cell because of glaucoma. Here's where your deviation map helps you again, because if you go to the deviation map, you can see another red circle sign. Okay, again, it's not a glaucoma pattern. And if you then go to your nerve fiber layer, look at that. It's like a Pac-Man cut surrounding the ganglion cell red circle sign. We've got arcuate, superior and inferior thinning. but it's crossing the horizontal midline right in the location of the papillomacular bundle. So that is not, again, a pattern that we would associate with a glaucoma patient. That's the last area to go. And that's why we use the papillomacular bundle as a reference plane for the old HRT Manesh. You know that one, yeah? So we start to see some evidence that what we thought was glaucoma might not be glaucoma. And if you look at the field, you'll be surprised because the field is clear. Don't be surprised when you see these very paracentral ganglion cell loss to see a clear visual field, because there's not many stimulus points that are following that area there. And if that's the case, you might do better to do a 10-2 field, because it will correlate much better with your OCT. Yeah. And I think this patient went on to become diagnosed with MS. Unfortunately, I don't have an MRI scan to confirm anything, but that's my understanding what happened with this patient. And they thought it was a glaucoma patient when they first came. Shall I finish now, or?
Yeah, please, you have some more
Yeah.
examples of other cases?
You want more? You want more?
Yeah, you had those with progression.
I've got
or,
normal tension. I got a normal tension here,
yeah,
or very early
normal tension
glaucoma.
you can show. Normal tension glaucoma.
Which one?
Normal tension glaucoma.
Normal tension. Okay. This is a lady coming saying, "Oh, please scan me." Okay. You can see, even just looking on the disc, you can see the pores of the lamina here, and you can see a large area of peripapillary arteries, an Asian lady. And we just follow the same routine from the rim. And looking on the profile is okay up to here. And then we see this dip again, temporal inferior, most common area that we see. She should be up here. She's down here. That's flagging up, is sufficiently large to flag up here. So don't really like the look of that. It's a large disc. Look, 3.46. So with a large disc, you might expect the profile to drop a little bit because all the nerve fibers are spread out. Okay. And you naturally get cupping with a larger disc, and you think that's what's suspicious of glaucoma, but it could be normal for a large disc to have a lot of cupping. But the profile could be a little bit lower than in the midline here. All right. On the other side of the coin, if you look at a small disc, all of your fibers are squeezed together and naturally push up a little bit higher profile with a small disc, let's say 1.5 millimeters squared or less. And of course, cupping is a very bad sign in a small disc, because you wouldn't expect to have the cupping because the nerve fibers are all squeezed together. So we've got a low little dip in the rim there. And if we look at the nerve fiber, we can see that we've got a little chunk out of our temporal inferior hump, which is consistent with what we've just seen on the rim as well. So that makes sense from a, let's say, early glaucoma perspective. The pressures of this lady were 12 and 13, so nothing really that high, although it depends on the patient, doesn't it? How high the pressure is and how much damage it might do to somebody. And then if we look at our posterior pole, and it's a holistic approach, I think it's really important to understand, to look at everything, because there may be one facet that stands out that makes you realize maybe it's not what I'm thinking it is. If you look at your posterior pole, we've got a fairly normal looking pattern in here, but we again got this kind of purple, almost a river going to the lake. We've got an asymmetry, inferior thinning compared to the superior hemifield. And we've got our little snail shell here, look, 44 compared to 36, little notching inferiorly. So it looks 3 strikes, unfortunately, for this lady who has got fairly normal pressures. And look, we start to see the early signs on the deviation map for the ganglion cell there. Again, inferiorly going horizontal towards the fovea. Yeah.
Yeah. Thank you, Mr. Martin, because we are running a little late now. So we can keep showing lots and lots of examples. I'm sure that it will be really interesting for both the glaucoma as well as on the neuroophthalmic, how the OCTs can be, how different it can be, and how to localize the signs and how to look for the progression. It is all very important. So we can go a little deeper. So we are just looking forward for the Glaucoma Society of India meeting so that we can teach even more. And probably we'll have more sessions. So Manish, you have, anything to add?
No, I think it was an excellent presentation with a lot of learning here. The only thing, the last thing about the high myope with the macular changes on the GC-IPL, the changes, and they are very convincing, but only by sides. Some of these myopic patients have quite a lot of macular distortions as well, and then it becomes, the going gets tough there, isn't it?
Yeah.
Also,
Always
one more question to Martin is that in myopic eyes, do you get more fluctuations? Like, do you get more variation from retest variations?
Yeah, I think they're very difficult, Manesh, to be honest with you. I don't think anybody has a golden answer to that. I've listened to many presentations at what to do. Some say look at the vertical asymmetry between the nerve fiber from the superior to the inferior is one other idea to see whether there is any difference. But I don't think there's any golden answer to this. I think you have to try to make a best assessment given the eye and what the history you know about your patient. And you probably know. I think it was Jos Jonas, who's done a lot of work in India. Said you probably have to assume that these patients are glaucoma until proven otherwise, and that's probably and he's an expert, so probably that's the best we can say, I think. Yeah.
Yeah.
There are a lot of motion artifacts also in myopic eyes and
Yes.
fixation losses,
Yeah.
artifacts. It's quite challenging in myopic eyes. So it is not that.
Yeah, I think so. I mean, you have the best, if you have good eye tracking, you have at least the best opportunity to try to stabilize the information that you're getting from your OCT. But honestly, probably because of the disruption close to the disc, those measurements are not really very reliable. So my understanding and what I've been taught was, in those cases, probably better to look on the ganglion cell and the macula to see whether you can see some familiar changes that look like glaucoma changes. Yeah.
Yeah. Thank you so much, Ms. Martin. Manish, thank you so much. And we are looking forward for more such sessions for more learning. Thank you all
right.
for your participation today.
Thank
you
you
very much. Thanks.
Good night. Thanks a lot.
Yeah.
See you.
See
Bye.
you.
Bye bye.